Okay, so I think Ivo did the hard job and I have an easy task. Because I only need to convince you that you have to tailor the risk to your strategy and, in other words, to tailor the hammer to the nail. And, okay, that's my disclosures that even if it's a TEVA symposium, this is my thoughts and I will share it with you. I will not draw on this slide just to show that a number of many studies which are examining the role of the anti-aggregation regimens in the treatment of coronary artery disease. But nowadays, our guidelines are based on two very old trials showing that in acute coronary syndromes, the more potent new anti-aggregation regimens have an advantage compared to clopidogrel. So what's the current paradigm? If you have acute coronary syndrome, you have to treat it with double anti-aggregation therapy for 12 months, with or without intervention, it does not matter. And despite this double anti-aggregation therapy, we still have quite a big number of patients dying or experiencing heart failure at the end of the first year. And both European and over-the-ocean guidelines says that we have to prefer prasugrel and ticagrelor over clopidogrel if we don't have atrial fibrillation or valve disease. But you can see here that we have a lot of interest which sparkled in the last few years about a renewed role of the clopidogrel. Why is that? It's because most of the time what we're trying to mitigate is the risk of stent thrombosis and thrombosis of the native plaques. And we're doing some intervention, modifying the risk, and nobody wants the intervention to be like a trampoline, which just pushes the patient in another trouble, as they say, out of the wood and out of the water into the frying pan. And of course, we have a lot of things that happened for the last 10 years because we have new stents and better medication for plaque progression control. And again, we're treating aging population with more comorbidities. And of course, we have a lot of studies now showing that different parts of the world have different genetics that maybe what's appropriate for Europeans is not appropriate for example, Asian people. Since long time, we know that bleeding in acute coronary syndromes equals mortality, and especially if you have STEMI, then if you have a bleed, then mortality is quite higher. And this risk is getting high early on. If you have a bleeding, first 30-day risk of mortality is quite high if you have no bleeding, but even to the first few months, this risk will be much higher if you have bleeding, never defining what's the site of the blood. So we know that both bleeding and thrombosis have a time-dependent risk, and they result in mortality. And we know that if you want to treat properly our patient, we need to define which are the high risk for bleeding and high risk for thrombosis in order to reduce mortality. At this slide here, I want to show you that this risk may be a time-dependent. And if you see the early stage after stent implantation, it's definitely risk from atrial thrombosis and stent thrombosis is much higher. But during the year, it's going down, and the risk of bleeding is a plateau. I don't want to say that the risk of bleeding is low early on, but just that the balance is different. And of course, we have a number of predictors for thrombotic risk, like biology of the patient, for example, chronic kidney disease or diabetes mellitus, a history of prior thrombosis, smoking, and of course, we have a lot of angiographic predictors depending on how severe is the disease and how long is the stent that we're using. Of course, we have a lot of predictors for bleeding. And the problem is that some of these are overlapping. For example, if you have a chronic heart failure, it increases both the risk of thrombosis and the risk of bleeding. So what shall we do? I think what we shall do is the art of medicine, and that's a dynamic risk adjustment. In the patient history, we have to consider bleeding, thrombotic risk, but also comorbidities, the side effects of our treatment, because if the patient is non-compliant, it doesn't matter how do you treat it, it will not take the drugs. And of course, in a country like ours, also the price is something that we have to consider. So now we come to the concept of de-escalation. The concept of de-escalation means that we try to use a very potent antiplatelet regimen early on after the acute coronary syndrome, and later we are moving to the less potent regimen because we don't want to have bleeding. And we try to be on the safe side. We have few options. We can move from the double antiplatelet to a single antiplatelet. Of course, we can switch from more potent anti-aggregation drug to a less potent but proven like clopidogrel. And all these methods are tried in a different studies. And I can tell you that almost all of them are showing that de-escalation have its benefits, but I will continue presenting the data for the strategy concerning de-escalation, changing from double antiplatelet with new anti-aggregation potent medicine to well-known clopidogrel. Of course, in some patients, you will need to escalate the treatment and not de-escalate, because when you see the patient after stent thrombosis, you don't want to repeat this event. So de-escalation is an option only for the patient when you consider the risk for bleeding to be prevailing over the risk of thrombosis. And the question is how to do it, when to do it, and what's the best strategy. And please remember, it's a dynamic risk, so what is true first week after the acute MI is not true maybe 6 months later. We have a few randomized clinical trials testing the strategy of de-escalating from ticagrelor to clopidogrel or from prasugrel to clopidogrel. And what is important, that all these randomized clinical trials do this de-escalation after 1 month of treatment. So all they prove that it is safe, and some of them are showing even a net clinical benefit because of much less bleeding. And why we don't have to do it early on? Because always if you de-escalate, you will have this increase of platelet aggregation. It's inevitable, and we don't want it to be very early on. And we have some data coming from the registry that if you decrease the level of anti-aggregation early on, you will see this rocketing of the thrombotic events, especially if you do it in the hospital. So please, if you want to de-escalate for a reason, don't do it early on. Wait 1 month and then de-escalate. I will draw my attention on 2 trials, topic trials. It's a trial which were de-escalating after 1 month with clopidogrel, and the other arm is continuing with the ticar or prasugrel. And this trial is not using any adjustment according to the laboratory measurements of the platelet activation. What we see, if we just switch to the less potent anti-aggregation regimen with clopidogrel, we have very nice effect, and this very nice effect, as expected, is mostly because we have less bleeding and less major bleeding. But I think that we all convinced that this matters. We have also a trial coming from Prague, in which is specific because most of the switches here are done for the economic reason. So the Czech guys are very pragmatic, and they say, okay, why pay more money if we can switch to a less expensive drug? And what they prove, that with this situation, you don't have any punishment. If you do late switch because you want to save some money, it's still safe. And we have also a tropical trial, which is doing this de-escalation based on the platelet reactivity. And maybe it's the safer approach, because what they do, they were trying just to find the patients who are good reactors to clopidogrel and to leave them on clopidogrel, and the patients who are not good enough, they think you should skip to prasugrel, and they say, you see they have the same curves, and topic trial, So this strategy is even more secure and works, and you have, of course, less bleeding, but no more thrombosis compared to the less potent regimen. So, okay, why do it first month? Why not 6 months? Why not third week? We don't know. Actually, we extract these data from the clinical trials, and that's the data we got. So the recommendation with the new generation drug-eluting stent, which are very thin struts, with our improved technique now, that at least for the first month after the PCI, we should stick to this regimen with more potent anti-aggregation. And later on, it depends on the biology of our patient, on the total length of the stent that we use. We can consider de-escalation in order to level the bleeding and thrombotic risk. And maybe in the future, we will have to think more during this first year and not just prescribing the medication and say to the patient, please come back in 1 year, I will switch your medication to the less potent one. We have some new data which are not published, showing that this is true, even more true for the patients from the Asian region, which are relatively a different genetic background and low body mass index. I think it's not something that will surprise us. So my final slide, why de-escalate? Why de-escalate? Because you have a big risk, or even you have some bleeding, because you have a history of intracranial hemorrhage, and because you feel that the patient biology is such that a risk of the bleeding prevails. Of course, we have to reassess this probably every other month. And not all patients can be de-escalated. Please de-escalate only patients which are stable, and when the biology and the data and the common sense are telling you that the risk of the thrombosis of the stent and the thrombosis of the native vessel is balanced. And now we have this recommendation, which is already in the 2020 European Society guidelines, that this strategy of de-escalation is viable after you are doing a thorough assessment of the patient risk. So thank you so much. That's my final.
Both presentations are open to discussion. Any comments? Thank you, Professor Velchev.